everyone. I am Nina Agbayani, Director of Programs at APCHO. On behalf of APCHO, I welcome you to the fifth in a five-part series of APCHO's Practice Transformation webinars. APCHO is a national association of 35 community health organizations dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and other Pacific Islanders. With the rapid changes that are occurring within the healthcare landscape, we hope we can better serve Asian Americans, Native Hawaiian, and other Pacific Islander community health centers with latest information on practice transformation. The previous webinars in this series provided the latest on quality improvement, meaningful use, accountable care organizations, and patient-centered medical homes, and explained how they affect all of you in your clinic. In this last webinar, we'll provide you with an analysis on the culture and language access standards that we are seeing in these practice transformation efforts. Today's webinar is entitled Ensuring Culturally and Linguistically Appropriate Services in Practice Transformation Initiatives, and our speaker is Ignatius Bao. Ignatius is a leader in health policy analysis, particularly around patient-centered care and healthcare reform. Prior to establishing his own consulting practice, Ignatius was a program officer and program director at the California Endowment, director of health policy and programs at the Asian and Pacific Islander Health Forum, and civil rights and immigration law attorney at the Lawyers Committee for Civil Rights of the San Francisco Bay Area. He was also part of the community efforts that resulted in the creation of the first White House initiative on Asian Americans and Pacific Islanders, and was a principal author on the first report from the President's Advisory Commission on Asian Americans and Pacific Islanders. Ignatius is a champion for the Asian American, Native Hawaiian, and Pacific Islander community, and a great APCHO supporter and ally. We are honored to have him with us today for this five-part series. Today's agenda will include a 45-minute presentation and a 15-minute session for questions and answers. So I'm going to pause here and wait for the slides to catch up. Before we get started, I wanted to review a few housekeeping items and let you know how you can participate in today's webinar. Here we are looking at an example of the GoToWebinar attendee interface, which is made up of two parts. The viewer window shown here on the right, but maybe on the left of your screen, depending on your browser or computer operating system, allows you to see everything the presenter will share on their screen. The control panel, shown here on the left, but maybe on the right of your screen, allows you to participate in the webinar. By clicking the orange arrow button, you can hide or show your control panel. You can also set the control panel to auto-hide or not to auto-hide by going to the View menu. Please note that all attendees are in listen-only mode and will be muted during Ignatius' presentation. You may submit questions in writing during the presentation by typing them in the questions field. We'll be reviewing questions as they come in, and we'll address them during the Q&A session held after the presentation. We can also facilitate a live Q&A session, so if you'd like to ask a question or make a comment, please raise your hand by clicking the hand icon on your control panel. When your name is called, your phone will be unmuted. Today's webinar is being recorded, and you will receive an email with a link to view a recording of today's presentation after the webinar. With that, I will pass it over to Ignatius.
Thanks, Nina, and welcome everyone to this last of our 5 webinars on practice transformation, and particularly focusing on how this will affect community health centers who are serving medically underserved Asian Americans, Native Hawaiians, and other Pacific Islanders. So today we're going to talk a little bit about the culturally and linguistically appropriate services standards, otherwise known as the CLAS standards. These standards have been around for quite a number of years, and we often don't think about these standards when we think about quality improvement issues like patient-centered medical homes or accountable care organizations, but I'm going to try to connect the two for everyone today in this webinar. And we'll talk about how then specifically community health centers that are engaged in practice transformation can use the CLAS standards as another tool in thinking about how best to improve the quality of care for their patients, particularly for Asian Americans, Native Hawaiians, and other Pacific Islanders. So as I said, the CLAS standards were developed by the U.S. Department of Health and Human Services Office of Minority Health in the year 2000, and so they have been around for a while. OMH then went through a several-year process of updating those standards, which ultimately resulted in what are called the enhanced CLAS standards that were released in April of 2013. And so we do have some polling questions in this webinar, and this first question is, any of you at your own community health center or organization have used the CLAS standards either as an assessment tool, a training tool, or a framework that helps you better understand how best to serve your patients? And so if you could answer yes or no on the poll, and then we'll collect the results and talk about them in a second. So one of the things that happened in the enhancement of the CLAS standards that were published in 2013 was that, if you notice, what I've done is have the language for the 2000 standards on the left and then the enhanced standards on the right. And so what you might notice is that the prologue says that the purpose of the CLAS standards is to advance health equity, improve quality, and eliminate healthcare disparities. And so it really elevates the quality improvement framework as part of what CLAS is really about. The other thing that was changed was, if you notice, that the wording in what is now called the principal standard really is framed around effective and equitable quality healthcare. So again, really reframing this as part of quality improvement and not as a standalone activity or something else that needs to be done. So in response to the poll, probably about a third of you have used the CLAS standards, and about 2/3 have not necessarily used the CLAS standards. And so hopefully, for those of you who are familiar with this, this will be reviewed. But for those of you who may not have actually used these standards, this might be more useful to you to understand how the standards work. So the next thing that we see in terms of these enhanced standards is that they're also very consistent with how the overall quality framework of thinking about person-centered care or patient-centered care, as well as equity, is important. And so here we see that the CLAS standards, by focusing on these elements of person-centered care or patient-centered care, are also consistent with where we're trying to go with overall quality improvement. And so the other thing that the CLAS standard added was a new standard, actually, which is now standard 2, that talks about organizational governance and leadership. And so the importance of this standard, again, as part of practice transformation efforts, is that this is not something that's limited to clinical staff or the staff that are seeing patients, but it really requires the commitment of the organization as a whole. And we know this in quality improvement that, again, it's not just through the single physician or the nurses or the medical assistants to be engaged in quality improvement efforts, but at a community health center, it requires the entire medical team, it requires the receptionist, it requires everybody, the health educators, everybody to be on board with the quality improvement. And so, again, the CLAS standards emphasize this now in the enhanced standards that were published in 2013. The CLAS standards also reflect that as a base for doing any kind of work to provide culturally and linguistically appropriate services, you have to have a workforce that is reflective and responsive to the population served. So particularly for community health centers who are serving Asian Americans, Native Hawaiians, and Pacific Islanders, recruiting and hiring Asian Americans, Native Hawaiians, and Pacific Islanders is really important. Whether that population is a dominant population in your service area or a growing or small population, it's equally important that you try to work with those communities to try to get individuals from those communities as part of your healthcare workforce. And then finally, this organizational commitment to training. We've talked a lot about the need for training and engaging all of your staff in quality improvement, and that includes training and engaging them in how to provide culturally and linguistically appropriate care. So the next set of standards, which are clustered in 4 different standards, are all about language assistance. This is really a core part of what we all understand in providing care to diverse populations, that many of our patients are going to speak languages other than English, in this case, Asian or Pacific Islander languages. And so having the kinds of comprehensive language assistance services, whether they're bilingual providers or trained interpreters available, is going to be really important, as well as having translated materials that they can read and take with them. And so when we talked in health information technology about moving information into an electronic environment, ensuring that language access in that electronic environment when they're dealing with health information in an electronic format, it's equally important to be thinking about how to continue to provide comprehensive language access to our patients who don't speak English as their first language. And so these 2 standards really talk about that it's not just providing any language services, but making sure that those types of services, whether they're providers or remote interpreters or on-staff interpreters, are trained and competent, and similarly that the translations that we use are done in a linguistically and culturally appropriate way. And so this next poll question is about how you at your community health center or organization might be doing in terms of providing comprehensive language services. And so here, really the yes is reserved if you feel like you are providing optimal language services and access, again, either through bilingual providers or through interpreters and through written translations for all your patients in multiple languages, or whether you have room for improvement in providing those kinds of language access services for patients in some languages. We know that many community health centers are going to see patients from the Asian American, Native Hawaiian, and Pacific Islander communities who speak dozens of different languages, and so it really is a and so again, we just wanted to get a sense of whether you feel like in your own assessment you're doing a good job for all your patients in all those languages, or that, again, know that you could do better. And we'll come back to that. So, again, where it's really important then to think about this, not just in terms of how language services are provided, but that this really becomes incorporated into everything that the community health center or the healthcare provider organization does. And so Standard 9 talks about accountability, really the accountability of management, and this notion of really infusing and integrating these ideas of culturally and linguistically appropriate services into everything that the organization does in terms of quality improvement and quality measurement. And so I actually like this idea of integration and infusion, as well as this idea of accountability that is really, really important. And so again, going back to the poll results, again, about a third of you feel like you have room for improvement, and it's really great that, again, about 2/3 of you feel like you actually are doing a good job of providing those comprehensive language services to your patients in multiple languages. And again, that's where APCHO centers in particular really have a lot to teach the field of how you really are able to provide those comprehensive language services in multiple languages to multiple patient populations. So then the CLAS standards talk about, and I'm going to spend quite a bit of time on this particular set of the standards because I think it's a starting point to really be thinking about not just issues of culture and language, but these broader issues of cultural competency and access for all our patients as we continue to try to serve our patients in the optimal way. And so these standards really emphasize the importance of collecting data individually from our patients, as well as collecting more broader population level, community level health assessments and needs assessments about the populations that we serve. And here the reminder is, and this is one of the changes in the CLAS standard, is that it broadened the definition of culture beyond race, ethnicity, and language to take into account issues of disability, issues of sexual orientation and gender identity, issues of income and education status, and really help us to understand that many of us have multiple identities. Many of us have multiple ways of self-identification, and that it's really important to consider all those axes, if you will, and those intersectional identities as we think about what is the best possible healthcare that we could provide and how do we provide healthcare in the most patient-centered way. And so doing this kind of continuous data collection both at the individual level and community level, again, is really fundamental. And I think while many of our APSHO centers do a great job in collecting race, ethnicity, and language data, there's opportunities for improvement in collecting this other kind of demographic data, and that's why I'm going to spend a little bit of time talking about this. We all know that the baseline are the Office of Management and Budget classifications, which are very broad classifications, and in this case, the classification Asian or the classification Native Hawaiian or other Pacific Islander is not going to be very helpful because we don't know whether that Asian patient is Chinese or Cambodian or Korean, and therefore has a whole different set of cultural and language issues that we need to pay attention to. And similarly, even including Native Hawaiians and other Pacific Islanders as a separate category isn't enough to understand whether they might be Compact of Free Association migrants or they might be Native Hawaiians and have, again, their own set of both language and cultural and other eligibility issues that we need to pay attention to. Unfortunately, while the Office of Minority Health has, under the Affordable Care Act, suggested that we do further stratify the Asian category into the 6 additional disaggregated or granular categories of Asian Indian, Chinese, Filipino, Japanese, Korean, and Vietnamese, and disaggregate the Native Hawaiian and Pacific Islander category into Native Hawaiian, Guamanian or Chamorro, and Samoan. This still isn't adequate, again, for many of our Asian American, Native Hawaiian, and Pacific Islander serving centers who are going to see a great deal more diversity than these additional categories that OMH suggests. In fact, the Institute of Medicine suggested that we should be looking at up to 900 different categories based on a really comprehensive list that the Centers for Disease Control and Prevention has developed, if we're really going to be meaningful in understanding the diversity of our race and ethnicity populations. Fortunately, and this is very, very recent, in a proposed rule that the Office of National Coordinator for Health Information Technology proposed last month, they finally have suggested that in electronic health records moving forward, that we finally use the CDC list that the Institute of Medicine recommended way back in the mid-2000s. And so we're slowly seeing movement that even though the Office of Minority Health has not yet recommended using the much more granular list, we may be seeing this introduced through health information technology. And so this is another way in which health information technology can really leverage and accelerate the way that we're being culturally and linguistically appropriate and use these measures in a way that will help our diverse Asian American, Native Hawaiian, and Pacific Islander communities. This is still a proposal, and it would not come into effect for a couple of years, but it would be a huge step forward in giving us the ability to collect this information, and again, rather than customizing and having to work with our EHR vendors about this, this would be a national standard. So no matter where we were geographically in the country, this would be a national standard for all electronic health record systems. So the next polling question is, even though the UDS system doesn't require us to collect patient race and ethnicity beyond the O&B categories, it doesn't even require us to use the OMH categories, let alone the CDC list of 900 categories. How granular are you collecting patient race and ethnicity? Are you going beyond the O&B categories, either in your electronic health record or using paper records? If you could weigh in yes or no on that, that would be really helpful. So moving along, though, I think this will be really important for, again, not just APCHO serving members, but members in all our community health centers, regardless of the size of population of Asian Americans, Native Hawaiians, and Pacific Islanders that they might be serving, to be making sure that they're collecting that information. And again, overwhelmingly, all 100% of you that responded say that you're going beyond either the yes requirements or the O&B requirements, which is great. And so again, you'll be helped now by this new proposed rule if it goes into effect, so that all electronic health records will have that information. So again, when you're exchanging that information, for example, with hospitals or other providers, with specialists, you'll also be able to both use the information that you have collected in exchanging that information with them, as well as get that information back from them in a way that will be most useful to your clients. Similarly, for language, which we know is a very, very important issue for culturally and linguistically appropriate care, OMH now has suggested that we ask the census question about how well someone speaks English, as well as whether or not the language is either Spanish or another language. And so again, this goes even beyond the UDS requirement, simply to collect whether or not the patient is served in a language other than English. Again, the Institute of Medicine recommended much more granularity or disaggregation, going beyond Spanish and actually asking not only the language proficiency question that OMH recommends now, but also listing those languages up to 600 categories. So again, the good news is in the same proposed regulation from the Office of National Coordinator for Health Information Technology, they are adopting the IOM, the Institute of Medicine recommendation, to use the list of up to 600 languages. And they've done it in this very technical way of referring to an internet engineering task force that maintains those languages, but it essentially is adopting the Institute of Language recommendation, which is great. So again, two really, really important developments on the race, ethnicity, and language policy level with this proposed rule that are really, really important. So then I think where there's room for improvement for all of us is first in the area of disability status, that OMH, as part of the Affordable Care Act, recommends these 6 questions, which are again from the census or the American Community Survey, that asks about disability status and functional status. There's an alternate question that is used in the Behavioral Risk Factor Surveillance Survey that is used by many states that actually is a much shorter question. And then there are much more complicated questions that were actually recommended by the National Committee on Vital and Health Statistics, as well as from the Institute of Medicine. These have not been adopted by the Office of the National Coordinator in the electronic health record environment, and so this is still an area that there's a lot of evolution and thinking, and we can answer more questions about that in the question and answer period. The other area of development is around sexual orientation and gender identity data, and this was recommended by the National Institutes of Health Commission report from the Institute of Medicine, and then followed up with a workshop that looked at specifically the feasibility of doing that in an electronic health record environment. And the Office of Minority Health is also looking at how best to include sexual orientation and gender identity data as well. Our colleagues at the Fenway Institute have really pioneered and led the way on developing appropriate questions both on sexual orientation and gender identity, and have tested that in community health center settings and found a high level of acceptability of those questions. And then finally, back to the same proposed rule from the Office of National Coordinator, they are also proposing that there be sexual orientation and gender identity questions included in electronic health record systems. The gender identity responses are still somewhat problematic in terms of how they're using the categories. They don't conform to the Fenway suggested categories. And so there's still additional work that needs to be done on this. The final area about demographic data, which is really exciting, is as we know that health is not just about health care, but also about the social determinants of health, and that we often need ways to measure how those social determinants impact our health. The Institute of Medicine recommended a number of measures, specifically thinking about an electronic health record environment that might begin to measure some of those social determinants, things like where someone lived, what their income was, issues like what kind of financial resources they might have, what their social connectivity might be, and issues like stress. And so finally, I won't get into this, but the same proposed rule from the Office of National Coordinator is also adopting many of these Institute of Medicine recommendations on using some of these measures and having the ability to record them in an electronic health record. And so again, I think this is, these are huge steps forward on race, ethnicity, language, sexual orientation, gender identity, and now the social and other behavioral data points that would be really, really useful to know about a patient. And so the last polling question is whether you all in your community health centers or other provider organizations are actually now collecting data beyond race, ethnicity, and language. Are you collecting disability data? Are you collecting sexual orientation and gender identity data? Are you collecting data about social and other determinants? And if you could weigh in on that, that would be great. I'm going to go forward, though, and talk about the importance of the final number of CLAS standards, really then talk about not just within a healthcare organization like a community health center, what a health center or another organization might do to really implement the spirit of the CLAS standards. And this talks about partnerships with communities, making sure that there's, again, a commitment to not only do these kinds of activities in terms of the implementation, but also really sharing that information with stakeholders and constituents and the broader public. And so this organizational commitment really goes beyond the walls of the organization and really requires that public accountability and that public reporting about what someone is doing in terms of these standards. Again, from the poll, it's great that 80% of you are saying that you are now collecting data beyond race, ethnicity, and language, and that really, again, demonstrates how many of you are leading the way in providing culturally and linguistically appropriate services to your patients. Again, thinking about the multiple identities and the intersectionality of all these issues for your patients, and that's a great thing, again, that community health centers like APCHO member centers can continue to lead on. There's obviously many things that we know from the work that APCHO and other organizations have done in terms of these community partnerships, that in Asian American, Native Hawaiian, and Pacific Islander communities, that it's really important for us to know who the elders are, to know where the family associations are, the clan and other extended family networks are, to use partnerships with ethnic media, to be thinking about faith-based organizations, so not just churches, but temples and other faith-based organizations that are relevant in our Asian American, Native Hawaiian, and Pacific Islander communities, forms of traditional healers, complementary and alternate medicine practitioners, arts and cultural organizations, and then obviously all the small businesses, whether they're restaurants or groceries or laundries or nail salons, many places in which there could be opportunities to partner with around health issues that address not only health care but the social determinants of health. These are all things that actual member centers know, but for other community health centers that are serving Asian Americans, Native Hawaiians, and Pacific Islanders, these are important things to be engaging in as part of that community partnership in order to provide culturally and linguistically appropriate care. There are many more ideas in the enhanced CLAS standards. This is a blueprint that has many of these kinds of ideas and details, and so I would commend you looking at that more closely, and again, these will be included in the resource list that we're making available after the webinar. The Department of Health and Human Services has also developed a couple of useful guides. This is an assessment profile that HRSA actually, the Health Resources and Services Administration, commissioned when the CLAS standards were first developed. And then there's a guide that is tailored for managed care plans but really can be used by anyone that the Agency for Healthcare Research and Quality also developed. The Office of Minority Health has also developed some online educational tools that are geared for physicians and nurses, and these are also, and now the latest one for actually oral health professionals, and so these are also useful, again, if you're looking for training materials, continuing educational materials for your staff. But I think looking forward to try to tie the CLAS standards into everything that we've talked about in the previous webinars around quality improvement and practice transformation, where CLAS is really, again, going to be integrated or infused in these other kinds of quality improvement and practice transformation activities, are going to be in other quality improvement standards. And so this national organization, the National Quality Forum, which is responsible for endorsing and really being a steward of a lot of different quality improvement measures that the Department of Health and Human Services often relies upon, way back in 2012, also developed a number of standards that it has endorsed that would help organizations move in addressing health disparities and cultural competency. And so this framework and these standards essentially adopted many of the elements of the CLAS standards repackaged in different ways. And so one of the endorsed standards, for example, was a toolkit developed by the measures that are in this now NQF endorsed standard are essentially the CLAS standards. And this is a toolkit that has been validated through some pretty rigorous research. Another tool that has also been endorsed by the National Quality Forum is a tool that RAND developed that, again, many of these implementation measures that RAND developed actually track the CLAS standards. And so this is another way in which CLAS has been infused and integrated into these quality improvement frameworks. Some additional measures are these items that measure specifically cultural competency, which again often track the culturally and linguistically appropriate standards, particularly around language access. And so these are consumer assessments that you can add to your CAP survey that AHRQ developed and now NQF has endorsed. Specifically for those individuals who are also struggling with health literacy, the NQF also endorsed the CAPS items specifically around health literacy. And again, we eventually need to see health literacy standards that are also addressing culture and language, and that would be an ideal third set, which has yet to be developed. But besides the National Quality Forum, the Joint Commission, which accredits hospitals, has also begun infusing these issues of cultural competence, culturally and linguistically appropriate services, patient and family-centered care into its standards for hospitals and other organizations that it accredits. And then we've talked a lot about the National Committee for Quality Assurance and specifically its recognition standards for patient-centered medical homes. It also has infused and integrated these standards into its work on patient-centered medical homes and accountable care organizations. And so the standards also show up in those recognition and accreditation standards that NCQA also puts out. And so as we continue to see the National Quality Forum, the Joint Commission, the National Committee for Quality Assurance, many other national quality organizations begin to pay attention to these issues, we will see the CLAS standards repackaged, renumbered, stated slightly differently, infused and integrated into these standards. And so the takeaways for community health centers who are serving Asian Americans and Native Hawaiians and Pacific Islanders is that you can use both the CLAS standards as well as these quality improvement frameworks in your practice transformation activities to make sure that you are providing optimal care to your Asian American, Native Hawaiian, and Pacific Islander patients. So again, whether they are the majority of your patients or a small part of your patients or a growing number in percentage of your patients, you can use both the CLAS standards and frameworks as well as the other quality improvement standards and frameworks that we've talked about in these webinars to really provide the optimal care for your Asian American, Native Hawaiian, and other Pacific Islander patients. And so with that, I will stop and see if there's any questions or answers and turn it back to Nina to moderate.
Okay, thanks, Ignatius. So we will now begin the question and answer section of our call, and you may participate in two ways. If you would like to submit a question, please do in the chat box on the right-hand column of your GoToMeeting screen, and I will read submitted questions for Ignatius to answer. And we can also facilitate a live Q&A session, so if you'd like to ask a question or make a comment, please raise your hand by clicking the hand icon on your control panel, and when your name is called, your phone will be unmuted. Okay, so Ignatius, our first question is, our health center has been seeing an increasing number of patients from Burma. What suggestions do you have to make sure we are providing culturally and linguistically appropriate services to our Burmese patients?
So that's a great question, and part of why we're seeing an increasing number of patients and populations from Burma is because if we look at the data that our Office of Refugee Resettlement puts out, Burmese refugees continue to be one of the highest number of, in terms of countries of origin, that we're admitting refugees from around the world. And so we have seen that for the last couple of years, and we'll probably continue to see that trend. And so those Burmese refugees may find their way to your community health centers when they're looking for health care. And so I think, as with any other population, it starts with the data and really understanding. In this case, Burmese refugees speak a whole number of languages in addition to Burmese, and they come from different ethnic and tribal groups. So really understanding where your Burmese patients and populations are coming from and what languages and dialects they speak. It may not be realistic if you're just beginning to see that patient population to be thinking about hiring someone from the community, but again, asking whether any of them have in the community through their elders and their family structures, anyone has a background in health that you might be considering as a staff member moving into a position to work at your health center to provide more culturally and linguistically appropriate care. Again, you may have difficulty finding an interpreter in person, and so you may need to rely on either training someone from the community to be a healthcare interpreter or using a telephonic line, but really making sure then your telephonic interpreter vendor has Burmese interpreters as well as Karen and some of the other common dialects. And then finally, I think everything I said about community engagement and community partnership is really important, that those Burmese refugees are probably eventually going to get connected, even if they're new in your area, to the existing networks of social service providers, faith institutions that are now growing and rapidly developing in the United States around the Burmese population. And so tapping into those community partners will also be really, really important for you to serve that population well.
Okay, thank you, Ignatius. Our next question is, can you give any examples of how the CLAS standards have been incorporated into other standards being used for practice transformation?
Sure. So as I may have run through quickly in some prior webinars, many of the standards, so again, we know in the meaningful use standards, you're required to collect race, ethnicity, and language data. So those are CLAS standards as well that are now part of the Health Information Technology Meaningful Use Standards. As part of the Patient-Centered Medical Home Standards that the National Committee for Quality Assurance puts out, again, it's not only the data collection requirements that mirror those meaningful use requirements, but there are separate standalone requirements that are actually named culturally and linguistically appropriate services that are part of the Patient-Centered Medical Home Standards. They're also part of the accreditation standards that NCQA puts out for accountable care organizations. And so there's a number of places in which these standards that are used for quality improvement and practice transformation purposes, like patient-centered medical homes and accountable care organizations, are actually adopting, integrating, and infusing CLAS standards into them. We expect that this will continue. Again, the information that I just presented about the proposed inclusion of additional demographic data elements into electronic health records, while they won't initially be part of meaningful use requirements, they'll just be capabilities that you'll have to have. You won't actually have to report on the percentage of patients that you're collecting that data from. Eventually, that will be a capability that everybody will have, and then we'll potentially see that also integrated into things like patient-centered medical home standards.
Okay, thank you. And we have another question. We have finally been able to record more granular race and ethnicity data in our electronic health record system. How should we begin to use that more granular data?
Sure. So again, it was great to see that 100% of those that responded to our quick poll during the webinar said that you were collecting more granular data. So for Asian populations, whether an individual patient that you're seeing is Chinese or Vietnamese or Filipino or Korean, is really, really important to understand not only their potential linguistic needs, but also their potential cultural needs around health education, around the tailored care plan. So I think if you have that information in your electronic health record, then making sure that that information is consistently used in scheduling so that you have interpreters available, making sure that that's consistently used in developing the panel for who is going to take care of that patient in a patient-centered medical home, so making sure that you're trying to match culture and language concordance with the provider or care team or somebody on the care team if you can. That may not always be possible, and you'll have to continue to use interpreters, but to the extent that you have that language and culture information about the patient, that goes into part of how you assign your providers to individual patients for patient-centered medical homes. And then when you're developing the care plan, really taking into account, especially is this individual patient that you may need to involve other family members in developing the care plan, making sure that you get the buy-in family members in developing the care plan with that patient and family. And then making sure that you have patient education materials, patient self-management materials available in the primary language of that particular patient. And then finally, as I discussed in the Patient-Centered Medical Home webinar, it's really important that providers also take somewhat of an advocacy role, an education role with other providers. So when you're talking to hospitals, when you're talking to specialists, when you're talking to other providers that you're trying to coordinate care with, are you raising the issue of culturally and linguistically appropriate care for that particular patient, and the capability and the education of those other providers to provide that care. So again, that might be something as simple as discharge procedures at the hospital, really asking that hospital and engaging in a conversation with the hospital discharge planning department. Do they have the capability to provide either in-language discharge instructions or to bring in interpreters that are trained and qualified? Do they have social workers that are planning the discharge, again, in a linguistically and culturally appropriate way? And as a provider at a community health center, you can do a lot to ensure that that whole continuum of care, those transitions of care, are done in a culturally and linguistically appropriate way. And having that information, that granular, disaggregated information in your electronic health record will allow you to know when those are issues and when those opportunities for education and maybe even a little bit of advocacy with those other providers is going to be really important.
Thank you so much, Ignatius. There are no other questions, so this concludes the Q&A session. And so this is the last of our practice transformation series. I wanted to give special thanks to our presenter, Ignatius, for bringing all this information to us over the past 5 webinars. And thank you all for joining, and we hope you found the webinars informative. This webinar has been recorded, and you will receive an email with a link to view the recording after this webinar. And for resources and information on APSHO, please visit our website at www.apsho.org. Goodbye.